Welcome back to the deep dive. Our mission here is simple. Take the most complex source material, the really dense graduate-level pharmacology, and we'll distill it down into pure, actionable knowledge for you.
That's the goal.
Today, we are undertaking, I think, a really critical and incredibly detailed journey. We're diving into the body's primary fluid regulator, Arginine Vasopressin, or AVP.
Right, AVP. And not just the hormone itself, but the whole ecosystem of drugs that, try to mimic it or sometimes block its effect.
That sounds fundamental.
Oh, it absolutely is. This is foundational if you want to really understand renal, cardiovascular, and endocrine physiology. And our sources today, they push us to use a very specific term right from the start. Antidiuretics.
Okay, antidiuretics. Let's unpack that. I mean, we usually just hear antidiuretic. What's the crucial difference here? Why are the sources stressing this term?
It really boils down to precision. It's about managing water specifically. Antidiuretics, by definition, are drugs that reduce your urine volume, okay? But they do it by inhibiting water excretion, critically, without messing significantly with salt excretion.
So they target free water clearance, not solutes, just H2O.
Exactly. Pure water management. And that kind of molecular selectivity, well, that's what makes them so potent for certain conditions.
Because if you're just losing water, not salt, you need something that targets just water replacement or retention.
Precisely. And this is why these agents are absolutely essential for treating diabetes insipidus, DI. That's really the central clinical challenge we're focusing on.
So our mission today is mastery. Mastering AVP's whole life cycle, right? From how it's made in the brain all the way to how we manipulate its receptor systems in the clinic. Sometimes elegantly, sometimes maybe a bit dangerously.
That's the plan, a complete deep dive.
All right, let's start at the beginning. The hormone itself, AVP, human antidiuretic hormone, ADH. But structurally, what is it? What are we actually looking at?
It's surprisingly small, actually. A tiny molecule, but incredibly powerful. It's an 8-arginine nonapeptide.
Okay, nonapeptide. 9 amino acids. And the 8-arginine tells us arginine is in the 8th position.
You got it. That's where the name comes from. And this tiny little thing controls how much water the entire body loses. It's amazing, really.
It really is. So where is this critical molecule actually made?
The factory is up in the brain, in the hypothalamus specifically. It's synthesized in the nerve cell bodies found in the supraoptic and paraventricular nuclei.
Okay, hypothalamus.
But it doesn't just pop out ready to go. It's made as part of a bigger precursor peptide, and then it gets transported down the nerve axon.
Right, down to the posterior pituitary.
Exactly, the neurohypophysis.
Right.
And it travels with a chaperone, a binding protein called neurophysin. That's a key detail.
Neurophysin, okay. So the posterior pituitary isn't the factory, it's more like the warehouse and shipping dock.
Perfect analogy. It's stored there and then secreted into the bloodstream when needed. Alongside another hormone, oxytocin, which is made in nearby cells.
Okay, storage and release. Now, the big question. When does the body decide to release AVP? What triggers it?
It's a really sophisticated control system, but there are two main drivers, two primary physiological stimuli.
What are they?
First, a rise in plasma osmolarity. Basically, your blood plasma is getting too concentrated, too salty.
Makes sense. Conserve water if you're getting salty. And the second?
The second is a contraction of the extracellular fluid volume. So if the total fluid volume outside your cells, in your tissues and blood, starts dropping.
Low volume, hang on to water, also makes sense. How does the body actually sense these changes? Osmolarity first.
Well, the standard answer is osmoreceptors in the hypothalamus. They directly monitor the blood's concentration.
Okay.
But here's where it gets really clever, something our sources highlight. There are also osmoreceptors in the hepatic portal system.
Wait, the hepatic portal vein? The blood vessel network coming straight from the gut to the liver.
Yeah.
Why?
Think of it as an early warning system. It's predictive. These receptors can sense a big salt load you've just ingested, maybe from a salty meal, before that salt has even been fully absorbed and raise the osmolarity of your entire bloodstream.
Wow. So it anticipates the osmotic load.
Exactly. It allows the body to release AVP preemptively. Start conserving water now because a salt wave is coming. It prepares the kidney ahead of time.
That's incredibly sophisticated physiology. Not just reactive, but proactive.
Uh-huh.
Okay, what about sensing volume? The second trigger.
For volume, we're looking at stretch receptors, mechanoreceptors. They're mainly in the low-pressure parts of the circulation.
Like the heart chambers?
Yeah, the left atrium, the ventricles, and also the pulmonary veins. If these areas aren't stretched as much, it signals low volume, and boom, AVP release is triggered.
And it's not just those.
No, it's modulated further. You also get input from the high-pressure baroreceptors, the ones monitoring blood pressure. And even higher brain centers can influence it. Things like stress, pain, fear, they can all tweak AVP release.
So it's this incredibly integrated system responding to chemistry, volume, pressure, even your emotional state. Wild.
Absolutely. Which brings us to how substances, including drugs, can mess with this control system, the pharmacological modulators.
Right. What enhances AVP secretion? What makes the body hold on to more water?
Well, there's a whole list. Some key endogenous signals include angiotensin II, that makes sense, part of the whole fluid balance system. Also, certain prostaglandins, histamine, neuropeptide Y, and acetylcholine.
Okay, internal signals. What about external things or drugs?
Nicotine is a classic one. Smoking can actually cause you to retain water via AVP. Also, some drugs like the antidepressant imipramine, and interestingly, high doses of morphine.
Ah, I saw that in the sources. Morphine seems complicated. High doses enhance AVP, but low doses inhibit. Can you explain that?
Yeah, it's a great example of dose dependency. High-dose morphine seems to stimulate AVP release, leading to water retention. But paradoxically, low doses of morphine and also the body's own endogenous opioid peptides tend to inhibit AVP release.
So maybe different opioid receptors involved or different downstream effects depending on how much is there?
That's the likely explanation. Different pathways kick in at different concentrations. It's a nuance worth remembering.
Definitely. Okay, what about the inhibitors? What shuts down AVP release and promotes water loss?
Well, the neurotransmitter GABA is inhibitory, and a big one is ANP, atrial natriuretic peptide.
Released by the heart when it's stretched too much, right? To get rid of volume.
Exactly. It's the natural counter-regulatory hormone to AVP in many ways. Pharmacologically, alcohol is the classic inhibitor. That's why you urinate so much when drinking.
The diuretic effect of booze.
Yep. Others include the antipsychotic haloperidol, the anti-seizure drug phenytoin, and glucocorticoids like cortisol or prednisone.
It's fascinating that common anti-inflammatory drugs like glucocorticoids also have this, significant effect on water balance.
It really highlights how interconnected these hormone systems are. You tweak one thing and there are ripple effects everywhere.
Before we move to the receptors, you mentioned the early days of trying to use this pharmacologically.
Right, just briefly. Initially, the only option was vasopressin derived from pigs. That's 8-lysine vasopressin or livepressin.
Livepressin, okay.
But it wasn't ideal. The big push was always towards synthetic analogs, things that were more potent, lasted longer, and crucially, could be made selective or even act as antagonist blockers. That drive for selectivity is what led us to the modern drugs.
Okay, so AVP is released. Now, where does it act? We need to talk about the receptors. The system is divided into V1 and V2 subtypes. What's the basic structure?
They're all G protein-coupled receptors, GPCRs, sitting there in the cell membrane waiting for AVP.
Standard GPCRs.
Yep. And they've been cloned, mapped out structurally, which was absolutely key for designing drugs that could target one type but not the other. The main functional split is V1 for sort of the systemic contractile effects and V2 for the kidney-specific water effects.
Let's tackle V1 first. That's the vasopressin part, right? The pressure effect. Where do we find V1 receptors?
V1 is pretty widespread, which explains its broad effects.
Yeah.
We subdivide it a bit further into V1A and V1B.
Okay, V1A.
V1A is the major player in smooth muscle. Think vascular smooth muscle, that's the key one for blood pressure, including in those important vasorecta vessels in the kidney medulla we'll come back to. Also uterine muscle, gut muscle, plus liver cells, platelets, fat tissue, even the brain.
So V1A is everywhere, causing contraction or other metabolic effects.
Yeah.
What about V1B?
V1B is more specialized. You find it in the anterior pituitary gland, where it's involved in releasing ACTH, also some specific brain regions and the pancreas.
Got it. Now the mechanism. How does V1 actually cause things like vasoconstriction? It's different from V2, right?
Oh, it's a different pathway. V1 receptors mainly work through the phosphatidylcholine C IP3D day pathway.
Okay, the PLC pathway.
Right. AVP binds, the G protein activates PLC. PLC then chops up a membrane lipid, PIP2, into 2 second messengers, IQ3 and DAG.
And IP3, that releases calcium.
Bingo. IP3 goes to the endoplasmic reticulum, binds its receptor, and triggers a rapid release of stored intracellular calcium ions, CT2+1.
And calcium is the universal signal for muscle contraction.
Precisely. That calcium flood is the immediate trigger for vasoconstriction in blood vessels or contraction in other smooth muscles.
What about the DAG part?
DAG stays in the membrane and activates another enzyme, protein kinase C or PKC. PKC then phosphorylates various proteins, which generally augments the calcium signal and the contraction. It's a two-pronged attack.
So V1 gives you a rapid, strong contractile response via calcium and PKC. But you mentioned a worrying long-term effect of V1 stimulation.
Yes, this is really important, especially for cardiovascular health. If V1 receptors are stimulated persistently, like in some chronic conditions, it doesn't just cause contraction, it actually activates protein cogens.
Genes involved in cell growth.
Exactly. This leads to the actual growth or hypertrophy of the vascular smooth muscle cells themselves. AVP isn't just tweaking tone, it can structurally remodel blood vessels over time.
Okay, that's a critical point. Now let's pivot to V2. This is the main player for the antidiuretic effect, the antiaquaretic star. Where is V2 primarily located?
The prime location is on the principal cells of the collecting ducts in the kidney. That's where the magic of water regulation happens.
Principal cells, collecting ducts. Got it. Any other locations?
Yes, a couple of important ones. V2 receptors are also found on cells of the thick ascending limb, the tail, another kidney tubule segment. There, they activate the NADA plus K plus 2-CO cotransporter, which helps reabsorb salt.
Okay, TLL cells too.
And perhaps surprisingly, you also find V2 receptors on the endothelium, the lining of blood vessels.
Wait, V2 on blood vessels? I thought V1 did the vessel stuff.
Mostly, yes. But V2 activation on the endothelium actually causes vasodilation. It's the opposite effect of V1.
Vasodilation from V2, vasoconstriction from V1,
Yeah.
from the same hormone. That seems like a built-in contradiction.
It is fascinating, isn't it? We'll come back to that. But first, the V2 signaling mechanism, how does it work?
It's different from V1's PLC pathway.
Completely different. V2 signals exclusively through the adenyl cyclase AC cyclic AMP pathway.
Ah, the classic KMP pathway.
That's the one. AVP binds V2, G protein activates AC, AC makes CAMP, and CAMP acts as the second messenger inside the cell. That's the entire focus for V2, cranking up CMP levels.
Okay, now here's a crucial point from the sources.
Yeah.
The difference in sensitivity between V1 and V2.
Yes, this is absolutely key to understanding how AVP works physiologically. The V2 receptors are significantly more sensitive to AVP than the V1 receptors are. Meaning they get activated and start the water-saving process at much slower concentrations of AVP circulating in the blood.
So under normal conditions, maybe when you're just a little dehydrated, the body primarily activates V2?
Exactly. It prioritizes water conservation. You get the antidiuretic effect without necessarily getting a big spike in blood pressure from V1 activation.
The V1 effects, the strong vasoconstriction, that's reserved for more extreme situations.
Precisely. That powerful pressor effect really only kicks in when AVP levels get very high, often pathologically high. Think severe dehydration, hemorrhage, shock. Situations where maintaining blood pressure becomes the absolute priority, even over fine-tuning water balance.
That sensitivity difference is physiologically elegant, and it's what drug developers exploited, right?
Absolutely. Understanding the structural differences and the sensitivity gap was the breakthrough. It allowed the creation of Desmopressin, or DDAVP, which is the super selective V2 agonist we rely on.
The water saver without the pressor effect.
Exactly. And on the flip side, it enabled the development of V2 antagonists, the blockers. Drugs like Tolvaptan and Mosavaptan, which are orally active, non-peptide molecules. These have really changed how we manage conditions of water excess, like hyponatremia.
All right, let's dive deep into that V2 mechanism in the kidney's collecting duct. This is where the antiaquaretic action happens. What exactly does V2 activation do to those principal cells?
It causes a dramatic, almost unbelievable increase in their permeability to water.
Makes them leaky to water.
Highly permeable, yeah. But this only works because of the environment. The kidney's inner region, the medulla, is kept incredibly salty hyperosmolar, up to 4 times the concentration of normal plasma in humans.
So there's this massive osmotic gradient pulling water out?
Exactly. When
Okay.
AVP makes the collecting duct walls permeable via V2, water just rushes out, following that gradient from the dilute urine inside the duct back into the salty medulla and then into the blood. The result: highly concentrated urine and water saved by the body.
And without AVP, or if V2 is blocked?
Then those collecting duct cells stay watertight, impermeable. The dilute fluid coming from upstream just flows right through, largely unchanged. You get massive volumes of dilute urine polyuria. That's the hallmark of diabetes insipidus. The whole system hinges on AVP's ability to install temporary water channels.
Okay, let's walk through that installation process. The V2-CKMP cascade, step by step.
Right. AVP hits the V2 receptor on the basolateral membrane, the side facing the blood. G protein activates adenyl cyclase. AC churns out EKMP inside the cell.
CKMP levels shoot up.
Yep. This surge of CAMP then activates a key enzyme, protein kinase A, or PKA.
PKA, the workhorse. What does it do?
PKA is like the foreman. It phosphorylates specific proteins. This phosphorylation event triggers the movement and fusion of special intracellular
Vesicles containing
the water channels themselves, aquaporin 2 channels, AQP2. These vesicles, sometimes called WCVs, water channel vesicles, move to the apical membrane, the side facing the urine, and fuse with it.
inserting the AQP2 channels like little pores into the membrane.
Exactly, like opening tiny doors for water to flow through. This insertion is the rapid response happening over minutes to hours.
So that's the immediate effect. But is that all?
No, there's more to the rapid action. At the same time, PKA activation also seems to inhibit the process of endocytosis, that's the cell, pulling those AQP2 channels back out of the membrane to degrade them.
Ah, so you increase insertion and decrease removal. Double whammy.
Right. You get a much bigger, sustained increase in water permeability that way.
What about longer-term changes? If someone is chronically dehydrated, does the system adapt?
It does. That's the long-term regulation. Continued stimulation of V2 receptors actually ramps up the synthesis of the AQP2 protein itself through gene expression. The increased CAMP levels activate transcription factors that bind to a specific part of the AQP2 gene called the CAMP response element, or CRE. This tells the cell, make more aquaporin 2 channels.
So AVP doesn't just manage the existing channels, it controls the factory output too.
Precisely. It ensures the cell is well stocked for ongoing water conservation needs.
We should probably mention the other aquaporins involved in getting the water all the way back to the blood. AQP2 gets it into the cell, but how does it get out?
Good point. AQP1 is found mainly in the proximal tubule, and the thin descending limb does a lot of the bulk water reabsorption upstream, and it's usually always active. Then, on the basolateral membrane of the collecting duct cells, the side facing the blood, you have AQP3 and AQP4.
So they provide the exit pathway.
Exactly. Water comes in the apical side through AQP2, crosses the cell, and leaves through AQP3 and AQP4 on the basolateral side, entering the salty interstitium and then the vanorectal blood vessels.
A complete water transport system. Now, AVP doesn't just work on the principal cell's water permeability, does it? It also seems to boost the efficiency of the whole medullary gradient system.
Yes, it's a system optimizer. Besides the AQP2 insertion, AVP has other rapid actions. One key one is activating a urea transporter in the intermedullary collecting duct. It's called VRUT, or UT1.
Urea transport. Why is that important?
Because pumping urea into the deep medulla actually helps make the medulla even saltier, or rather, more osmotically concentrated. It augments the hypertonicity, strengthening the driving force for water reabsorption.
So it makes the sponge even spongier, helps pull more water out.
You could put it that way, yeah. And there's another rapid effect. AVP also stimulates that non-dollar plus K plus 2Cl cotransporter in the thick ascending limb, the TL cells we mentioned.
It's helping pull more salt out of the filtrate upstream.
Right, which also contributes to the medullary gradient and delivers more dilute fluid to the collecting duct, maximizing the potential for water recovery. And just like with AQP2, over the longer-term days, AVP also upregulates the expression of this TL cotransporter gene.
So it reinforces the salt pumping machinery, too. AVP really coordinates the whole water-saving effort.
It really does.
Okay, now we have to address this V1 renal paradox. It sounds weird. Why would the V1 receptor, the vasoconstrictor, be active in the kidney in a way that seems to both help and hinder the main V2 water-saving job?
It is paradoxical, but it seems to act like a sophisticated safety mechanism, a physiological brake. Let's look at how V1 helps first.
Okay.
V1 receptors are found on the vasa recta, those specialized blood vessels that dip down into the medulla. AVP binding here causes vasoconstriction.
Constricting blood flow in the medulla, how does that help?
By slowing down blood flow through the medulla, it reduces the rate at which the blood carries away the solutes, the salt and urea that make the medulla hypertonic. It minimizes the washout effect, helping to maintain that crucial high osmolarity needed for water reabsorption.
Okay, so V1 constriction of the vasa recta helps preserve the gradient V2 needs to work. That makes sense. Now, how does V1 hinder V2 action, and why?
This seems to be a protective mechanism against over-retaining water, especially when AVP levels are pathologically high, like during shock.
A brake system.
Exactly, two ways. First, V1 receptors are also found on certain cells within the medulla called interstitial cells. When AVP hits these V1 receptors, it stimulates them to produce prostaglandins, PGs.
And prostaglandins.
Prostaglandins are known local inhibitors of V2 action. They interfere with the adenylyl cyclase system, reducing CAM-MP generation in the collecting duct cells. So high AVP triggers its own local countersignal via V1 and PGs, dampening the V2 effect.
Wow. Okay, so PGs put the brakes on V2. What's the second mechanism?
There are also V1 receptors directly on the collecting duct principal cells themselves. Activation of these V1 receptors uses that PLC-PKC pathway we talked about earlier.
Right, the calcium PKC pathway.
And it turns out that activation of PKC directly reduces the responsiveness of the collecting duct cell to V2 receptor stimulation. It makes the cell less sensitive to the TMP signal generated by V2.
So high AVP essentially tells the collecting duct cell, okay, I'm here in force, but maybe don't go completely crazy retaining water.
That's a good way to think about it. It restricts the maximal V2 effect, acting as a ceiling, particularly when AVP levels are extremely high for pressor reasons. This likely helps prevent catastrophic water intoxication and brain swelling in those extreme scenarios.
An internal safety valve. That's incredibly complex.
It is, and it has clinical implications. For example, NSAIDs like indomethacin block prostaglandin synthesis.
So they remove the PG brake.
Exactly. That's why indomethacin can potentiate the antidiuretic effect of AVP. It takes away one of the V1-mediated inhibitory signals. Conversely, drugs like lithium or the antibiotic dimethylcycline can cause nephrogenic DI, partly because they interfere with CMP generation, mimicking a V2 blockade.
And we also noted carbamazepine and chlorpropamide can potentiate AVP.
Yes, they seem to sensitize the collecting duct to existing AVP. Useful in some cases of partial neurogenic DI, the whole system is clearly tunable at multiple points.
Okay, let's pull back on the kidney for a moment and look at AVP's broader systemic effects again. The name vasopressin wasn't an accident. Remind us about the V1 action on blood vessels.
Right. Via those widespread V1 receptors, AVP is a potent vasoconstrictor. It clamps down on blood vessels, increasing total peripheral resistance.
Which should increase blood pressure.
It should, and it can. But it's important to remember that in a healthy individual, if AVP levels rise moderately, the body often compensates. The increased resistance might trigger a reflex slowing of the heart rate or decrease in cardiac output, so the net effect on blood pressure might be minimal initially.
The Boreflex compensation. But that reflex can be overwhelmed.
Definitely. In situations like hypovolemic shock, where blood pressure is already dangerously low, or if you give high pharmacological doses of AVP, that reflex compensation fails or is insufficient. Then you see a significant rise in blood pressure. That's why it's used as a pressor agent in critical care.
Which blood vessels get constricted the most? Is it uniform?
No, it's selective. AVP tends to constrict blood vessels in the skin, causing pallor, the gut, mesenteric circulation, skeletal muscle, fat tissue, the thyroid gland, and importantly, the coronary arteries supplying the heart muscle.
Coronary constriction, that sounds risky.
It is a major concern, especially with non-selective agents. And remember that long-term V1 effect chronic exposure can lead to that vascular smooth muscle hypertrophy, actually thickening the vessel walls.
Okay, now back to that V1, V2 contradiction on blood vessels.
Yeah.
V1 constricts, but you said V2 vasodilates. How does that work?
Yeah, the V2 receptors located on the vascular endothelium, the inner lining of blood vessels, trigger a different response. When AVP binds there, it stimulates the production of nitric oxide, NO.
The classic vasodilator signal.
Exactly. So V2 activation leads to NO-dependent relaxation of the smooth muscle, causing vasodilation. This effect is usually masked by the much stronger V1 vasoconstriction when you use native AVP.
But you could unmask it.
Yes. If you block the V1 receptors pharmacologically, or more relevantly, if you use a highly selective V2 agonist like desmopressin. Since desmopressin barely touches V1 receptors, any vascular effect it might have would lean towards the subtle V2-mediated dilation, not constriction.
Interesting. What about effects outside the vascular system, other smooth muscles?
AVP contracts most other visceral smooth muscles too, via V1 receptors. This is why common side effects include increased gut motility leading to abdominal cramps, sometimes nausea, and that urge to defecate or pass gas.
Okay. Any effect on the uterus?
Yes. It causes uterine contraction. It actually acts on oxytocin receptors in the uterus. Interestingly, AVP and oxytocin are about equally potent at contracting the non-pregnant uterus. It's only right at the end of pregnancy that the uterus becomes much more sensitive specifically to oxytocin.
Fascinating overlap. And you mentioned V2 has a crucial role in blood clotting.
Absolutely critical. Those V2 receptors on the vascular endothelium aren't just making NO, they also trigger the release of two key clotting factors, factor VIII and von Willebrand factor, BWF.
Which is why desmopressin is used in bleeding disorders.
Exactly. It's a purely V2 mediate effect separate from water balance. AVP also has some metabolic effects. It can cause platelet aggregation via V1 and trigger glycogen breakdown in the liver.
And briefly, what about the brain? AVP is made there. Does it act there too?
Yes, AVP also functions as a neurotransmitter or neuromodulator within the brain and spinal cord itself. It's involved in regulating things like body temperature, blood pressure control centers, the release of ACTH, and even learning and memory processes. Though it's important to note that AVP given systemically doesn't really cross the blood-brain barrier well.
Okay. Lastly for this section, pharmacokinetics. How easy is it to actually use AVP as a drug?
Native AVP is quite difficult to use for chronic therapy. Being a peptide, it gets chewed up by enzymes like trypsin in the gut, so it's completely inactive if you take it orally.
It has to be injected or maybe nasal spray.
Right. Parenteral or intranasal. And even then, its lifetime in the blood is very short. The plasma half-life is only around 25 minutes.
Wow, very fleeting.
Yeah, it's rapidly broken down by enzymes, mainly in the liver and kidneys. An injection of simple aqueous vasopressin might only work for 3 or 4 hours. That's just not practical for managing something like DI long-term.
Which explains the intense search for better analogs.
Absolutely. The short duration and oral inactivity of native AVP were huge drivers for developing synthetic versions like desmopressin.
Okay, let's talk about those analogs, starting with the star player for antidiuresis, desmopressin, DDAVP, the V2 specialist.
Desmopressin is really the poster child for successful, rational drug design based on understanding the hormone and its receptors. It's a synthetic peptide tweaked structurally from native AVP.
And those tweaks achieve two key things.
Exactly. First, high selectivity for the V2 receptor. It's about 12 times more potent than AVP as an antidiuretic, but its V1 vasoconstrictor activity is almost negligible. Minimal pressor effect.
Which is huge for safety, right? Avoids the blood pressure spikes and coronary issues.
Absolutely. That's the first big win. The second win is pharmacokinetics. Those structural modifications make it much more resistant to the enzymes that break down AVP.
So it lasts longer.
Much longer. Its plasma half-life is around 1 to 2 hours, and clinically its duration of action is typically 8 to 12 hours. That makes once or twice daily dosing feasible for chronic conditions.
Huge improvement over native AVP's 3-4 hours. Now, how is it given? You mentioned oral wasn't good for AVP. What about desmopressin?
It's better, but still tricky. The intranasal spray was the standard for a long time. Bioavailability that way is decent, maybe 10 to 20%.
Okay.
There is an oral tablet formulation now, which patients often prefer for convenience. However, its oral bioavailability is really low, only about 1 to 2%.
1 to 2%, that's tiny.
It is. And it means the oral dose has to be much, much higher, maybe 10 to 15 times higher than the intranasal dose to get the same effect. That's a critical point for clinicians to manage if switching formulations. Big risk of under or overdosing if you don't account for that huge bioavailability difference.
Good point. Okay, uses. Given its V2 selectivity, where is desmopressin the clear drug of choice?
The number one indication, the most important one, is neurogenic diabetes insipidus, also called central DI. This is where the problem is insufficient production or release of AVP from the brain.
So desmopressin replaces the missing hormone's V2 action.
Precisely. It provides effective, often lifelong, control of the polyuria and polydipsia. Dosing needs careful individualization, usually guided by monitoring 24-hour urine output, to avoid giving too much and causing water retention.
And it's also used diagnostically.
Yes, it's crucial for diagnosis. If someone comes in drinking and urinating excessively, you give them a test dose of desmopressin. If their urine volume drops significantly and their urine becomes concentrated, that points strongly to neurogenic DI.
And if they don't respond?
If there's no response, it suggests the problem isn't lack of hormone, but that the kidney itself can't respond to it. That's nephrogenic DI, and desmopressin won't work there.
Makes sense. What's the other really common use, especially at night?
That would be nocturia, waking up frequently at night to urinate, and also primary nocturnal enuresis, which is bedwetting, mainly in children, but sometimes adults too.
How does it help there?
You take it at bedtime and it suppresses urine production overnight, reducing the need to void. But this comes with a massive safety warning.
The fluid restriction.
Absolutely critical. Patients must restrict fluids for at least 1 hour before taking the bedtime dose and for the next 8 hours afterwards. If they drink freely while the drug is suppressing urine output, they can rapidly develop dangerous hyponatremia.
Water intoxication. That cannot be stressed enough, especially when prescribing for kids.
Couldn't agree more. Patient and parent education is paramount there.
Okay, neurogenic DI, nocturnal issues.
Mm.
What's the third main use, leveraging that non-renal V2 action?
That's for certain coagulation disorders, specifically mild to moderate hemophilia A and von Willebrand's disease, type 1.
Because V2 releases factor VIII and VWF.
Exactly. An intravenous infusion of desmopressin over about 30 minutes can temporarily boost the levels of these clotting factors released from the vascular endothelium. It can be enough to control bleeding during minor surgery or dental procedures in these patients, often preferred over blood products because it avoids transfusion risks.
Okay, so desmopressin is the V2 workhorse. What about drugs targeting V1? You mentioned lipressin and terlipressin.
Right. Lipressin, the older pig-derived one, hits both V1 and V2, but its use leaned towards V1 effects. The more key player now is terlipressin.
Terlipressin, what's special about it?
Terlipressin is interesting. It's a synthetic prodrug. It gets administered, and then enzymes in the body slowly cleave it to release active lysine vasopressin over time.
Ah, so it provides a slower, more sustained V1 effect compared to just injecting vasopressin directly.
Exactly. And its main use leverages that V1 vasoconstriction, specifically for controlling bleeding esophageal varices.
Varices, those swollen veins in the esophagus, often from liver disease.
Right. They can rupture and cause catastrophic bleeding. Terlipressin, by causing V1-mediated constriction of the mesenteric blood vessels supplying the gut, reduces blood flow into the portal vein system.
Lowering the pressure in the varices.
Precisely. It reduces the flow and pressure feeding into those fragile varices, which can help stop the bleeding and allow a clot to form. Terlipressin is generally preferred over vasopressin now because that slower release seems to cause fewer intense side effects, especially cardiac ones, and studies suggest better survival rates.
Is it the only option for varices?
No, it's usually used alongside endoscopic treatments like banding. And another drug option is octreotide, a somatostatin analog, which also reduces portal pressure through a different mechanism. But terlipressin is a key pharmacological tool here.
Any other minor V1 uses?
Occasionally, vasopressin or terlipressin might be used before an abdominal X-ray. The V1 effect on gut motility can help expel bowel gas, which can obscure the image. Not a common use these days, though.
Okay, we're manipulating a system that controls body fluid volume and blood pressure. The potential for adverse effects must be significant if things go wrong.
Absolutely. The side effect profile really depends on whether you're dealing with a selective V2 agent like desmopressin or a non-selective one like AVP or terlipressin that hits V1 hard.
Let's start with desmopressin. Being V2 selective, it avoids the worst V1 issues, right?
Mostly, yes. The common side effects are usually milder. Things like transient headache, maybe some facial flushing, if using the nasal spray, local irritation, runny nose, sometimes nosebleeds. Epistaxis can happen.
But even desmopressin can cause some systemic effects shared with AVP due to maybe trace V1 or other actions.
Well, some non-specific effects can occur with any AVP-like drug. Nausea, abdominal cramps, that feeling of needing to defecate, maybe some pallor. These likely reflect some smooth muscle stimulation. Backache can happen in women due to uterine effects.
But the absolute biggest risk, the most dangerous potential side effect, especially with desmopressin overdose or ignoring fluid restrictions.
Is fluid retention leading to dilutional hypernatremia? Low sodium in the blood?
Explain why that's so dangerous again.
If the drug forces the kidneys to retain too much free water, it dilutes the sodium in the bloodstream. Water then moves osmotically from the low-sodium blood into body cells, trying to equalize the concentration.
Including brain cells.
Including brain cells. This causes the brain cells to swell cerebral edema.
And the symptoms of cerebral edema.
They can range from headache, nausea, and lethargy to more severe signs like mental confusion, disorientation, and ultimately seizures, coma, and even death. It's a neurological emergency.
And you mentioned children are particularly vulnerable.
Yes, they seem to be more susceptible, which is why the warnings around fluid restriction with desmopressin for bedwetting are so critical. Dose titration has to be incredibly careful.
Okay, that's the major V2-related risk. Now, what about the risks specific to drugs with significant V1 activity, like native AVP, lipressin, or terlipressin?
Here you add the cardiovascular dangers on top. Because of V1 vasoconstriction, including the coronary arteries, these drugs can cause a slowed heart rate, bradycardia, increase the workload on the heart, increase afterload, and most seriously, precipitate angina or even a heart attack in susceptible individuals.
So definite contraindications there.
Absolutely. These agents are generally contraindicated in patients with known ischemic heart disease, significant hypertension, or chronic kidney disease, nephritis, where fluid retention is already an issue.
And one absolutely critical contraindication related to behavior.
Psychogenic polydipsia. This is a condition where people compulsively drink excessive amounts of water, not because they're physiologically thirsty. Giving an antidiuretic drug to someone who is already waterlogged is a recipe for disaster, rapid, severe, potentially fatal water intoxication.
Got it. Never give these drugs if the problem's excessive intake, only if it's excessive loss or lack of AVP.
Exactly.
Now let's shift gears to one of the most fascinating paradoxes in this field. Thiazide diuretics. Drugs designed to make you lose water acting as a treatment for diabetes insipidus, a disease of water loss. How on earth does that work?
It is truly counterintuitive, isn't it? But thiazide diuretics like hydrochlorothiazide do have a modest but definite antidiuretic effect in patients with DI. And crucially, they work in both neurogenic and nephrogenic DI.
Even when the kidney can't respond to AVP at all?
Yes. That makes them incredibly valuable for nephrogenic DI, where desmopressin is useless. The effect isn't as strong as desmopressin in neurogenic DI, but it can reduce urine output significantly.
Okay, the mechanism.
Yeah.
This is the million-dollar question. How can a diuretic conserve water?
The leading theory revolves around creating a state of mild chronic volume depletion and salt loss.
Okay, the diuretic does its job initially, depletes volume and salt. Then what?
This chronic, low-grade depletion triggers compensatory changes upstream in the nephron, specifically in the proximal tubule PT.
The first part of the tubule system.
Right. The body senses it's low on salt and volume, so it ramps up the reabsorption of sodium, and water follows osmotically much earlier in the system in the PT. Think of it as the body trying to reclaim as much filtrate as possible, as early as possible.
So more fluid gets reabsorbed way back in the proximal tubule.
Which means significantly less fluid volume is delivered downstream to the collecting ducts.
Even if the collecting ducts are still impermeable to water, as in nephrogenic DI, there's just less water arriving there to be excreted in the first place.
Exactly. You're reducing the total volume load presented to the final segment, so the final urine volume goes down. It doesn't make the urine highly concentrated, but it reduces the polyuria. The fact that simply restricting dietary salt can also have a similar antidiuretic effect in DI really supports this mechanism. Both strategies reduce the load delivered distally.
That's brilliant. A paradox explained by upstream compensation. So thiazides are key for nephrogenic DI. Are there other drugs used to help manage DI, perhaps by potentiating AVP?
Yes. We mentioned indomethacin, the NSAID. By blocking renal prostaglandin synthesis, it removes that V1-mediated braking effect on V2 action, making the kidney more responsive to whatever AVP is present.
Okay, indomethacin boosts AVP's effect.
And two older drugs, carbamazepine, an anti-seizure med, and chlorpropamide, an old diabetes drug rarely used now, were also found to potentiate AVP's action, likely by increasing CMP levels or sensitivity in the collecting duct. They could sometimes help in partial neurogenic DI.
Now, a very specific type of nephrogenic DI, the one caused by lithium treatment.
Right, lithium is notorious for causing nephrogenic DI. It gets into the principal cells through the same channel sodium uses ENA-C, and once inside, it messes up the V2 signaling cascade, making the cell resistant to AVP.
Is there a specific treatment for that?
Yes, the drug of choice is amiloride.
Why amiloride?
Amiloride is a potassium-sparing diuretic that works by directly blocking that ENA-C sodium channel on the apical membrane of the principal cell. By blocking ENA-C, it prevents both sodium and, crucially, lithium from entering the cell in the first place.
So it protects the cell from lithium's toxic effect on the V2 pathway.
Exactly. It prevents or reduces the lithium-induced damage. Amiloride can often be combined with a thiazide and maybe indomethacin for maximal effect in managing lithium-induced nephrogenic DI.
Okay, we've spent a lot of time on how to make the body hold on to water, using AVP agonists or potentiators. Now let's flip the script. What about drugs designed to make the body excrete free water, the AVP antagonists or aquaretics?
Right. These are drugs that block the action of AVP, specifically at the V2 receptor in the kidney. Their main purpose is to increase the excretion of solute-free water.
In the clinical situation where you'd want to do that.
Primarily to correct hyponatremia, low plasma sodium concentration. This often happens in conditions where there's too much ADP activity relative to the body's needs, leading to excess water retention.
Like SIADH.
Exactly. Syndrome of inappropriate ADH secretion, SIADH, is a classic indication, but also hyponatremia associated with congestive heart failure, CHF, or liver cirrhosis, where AVP levels are often elevated inappropriately.
And the main drug here is Tolvaptan.
Tolvaptan is the key player currently. It's an orally active, non-peptide, highly selective V2 receptor antagonist.
So it binds to the V2 receptor on the collecting duct, but doesn't activate it.
Precisely. It competitively blocks AVP from binding and initiating that whole CAMPAC-UP2 cascade.
Effectively making the collecting duct impermeable to water again.
Yes. It functionally disconnects the collecting duct's water permeability from circulating AVP levels. The result is that the kidney excretes the excess free water, concentrating the plasma sodium back towards normal levels. It promotes aquaresis water loss without significant salt loss.
Sounds powerful. But you hinted earlier this is a dangerous balancing act. What's the major risk with using Tolvaptan?
The danger is correcting the hyponatremia too quickly.
Why is rapid correction bad?
If plasma sodium rises too fast, it can cause water to be pulled out of brain cells too rapidly. This osmotic stress can lead to a devastating neurological condition called osmotic demyelination syndrome, historically known as central pontine myelinolysis. It causes severe, often permanent brain damage.
So correction needs to be slow and controlled.
Absolutely critical. There are strict guidelines about the maximum rate of sodium correction per hour and per day. Treatment initiation usually requires hospitalization and very close monitoring of serum sodium levels. The sources also mention a potential risk of thrombotic events due to rapid hemoconcentration if water is pulled out too fast.
A powerful tool, but needs extreme caution. What are the common, less severe side effects? Probably related to losing water.
Exactly. The most frequent side effects are thirst and dry mouth because the drug is effectively making you excrete water. Patients will feel thirsty, which is actually a protective mechanism. Other reported effects include fever, some GI upset, and occasionally hyperglycemia.
And how is it handled by the body?
Tolvaptan has a decent half-life, around 6 to 8 hours, allowing for once-daily dosing typically. But a key point is its metabolism. It's broken down primarily by the cytochrome P450 enzyme CYP3A4.
The common drug metabolism pathway.
Yes, which means you have to be extremely careful about drug interactions. Co-administering Tolvaptan with strong inhibitors of CYP3A4, like ketoconazole, clarithromycin, ritonavir, can dramatically increase Tolvaptan levels and the risk of overly rapid sodium correction. Conversely, CYP3A4 inducers, like rifampin, can reduce its effectiveness.
Lots to consider there. Is Tolvaptan the only antagonist used?
It's the main oral V2 selective one. There's also mosavaptan, another V2 selective agent used in some regions. And then there's conivaptan.
Conivaptan, how is it different?
Conivaptan is different because it blocks both V1A and V2 receptors. It's given intravenously, typically in a hospital setting. The dual blockade might be useful in certain situations, maybe where some V1 blockade could also be beneficial, for instance, in heart failure patients.
Wow. This has been a genuinely deep dive. We've really dissected the AVP system from synthesis to antagonism. I feel like we've achieved that mastery goal. We've clearly seen the two fundamental sides of AVP. The V2 side, managing water in the kidney, the antidiuretic role, and the V1 side, managing vascular tone, the pressor role.
Absolutely. And we've traced how that duality plays out pharmacologically. The precision of selective V2 agonism with Desmopressin, life-changing for neurogenic DI, helpful for bleeding disorders. Then the targeted V1 constriction with Terlipressin for critical situations like variceal bleeding.
And those fascinating paradoxes, like the thiazides, diuretics acting as antidiuretics in nephrogenic DI by manipulating upstream reabsorption, and the intricate V1-V2 interplay within the kidney itself, acting as a safety brake.
It's an incredibly elegant, complex system, and the source material really forces us to confront the therapeutic tightrope walk. On one hand, you have V2 agonists like desmopressin, incredibly useful, but carrying the risk of cerebral edema from hyponatremia if misused.
And on the other hand, you have V2 antagonists like Tolvaptan, specifically designed to correct that hyponatremia, but whose use is limited by the danger of correcting it too fast and causing neurological damage.
Exactly. It highlights this razor's edge in clinical practice. When you're manipulating the body's core systems of fluid volume and electrolyte concentration, the difference between therapeutic success and causing serious harm like brain swelling or demyelination can come down to careful dosing, meticulous monitoring, and understanding these powerful mechanisms.
So given that inherent risk, particularly the danger of rapid electrolyte shifts with both agonists and antagonists, and the complexity we've uncovered. Here's the final thought for you, our listeners, to ponder. How should clinicians best integrate advanced monitoring or predictive strategies to manage these risks? How do we ensure safety when walking this pharmacological tightrope that controls the very water within our cells?
That's the crucial question for applying this mastery in practice, something to really think about. Thank you for joining us on this deep dive.
We'll see you next time on The Deep Dive.